Guys, so today we are going to continue our book club meetings for the fundamentals of diagnostic radiology, the fourth edition. Today we will talk about chapter 7, which is white matter and neurodegenerative diseases, presented by your colleague Dr. Faryad Anwar Shallar.
White matter and neurodegenerative diseases. In contrast to gray matter, which contains neuronal cell bodies, white matter is composed of long processes of these neurons. The marked sensitivity of T2-weighted images allows white matter lesions to be readily detected, providing high sensitivity to lesion detection. Cerebral white matter diseases are classified into two main categories: demyelinating and dysmyelinating. Demyelination affects normal myelin, that say it's occurring in adult age group, while dysmyelination affects formation or maintenance of myelin, which is which occurs in pediatric age group, and all are rare. Demyelinating disease can be divided into four main categories on the basis of etiology: primary, ischemic, infectious, toxic, and metabolic. Primary demyelination like multiple sclerosis, ischemic demyelination like deep white matter infarction, lacunar infarction, vasculitis, dissection, thromboembolic infarctions, migrainous ischemia, moya disease, and post-anoxia. Infection-related demyelination like progressive multifocal leukoencephalopathy, HIV encephalopathy, acute disseminated encephalomyelitis, subacute sclerosing panencephalitis, Lyme disease, and neurosyphilis. Toxic and metabolic demyelination like central pontine myelinolysis, Machiavava-Bignami disease, Wernicke-Korsakoff disease, radiation injury, and necrotizing leukoencephalopathy. Demyelinating later we discuss the subject. Primary demyelination, multiple sclerosis, multiple CNS lesions separated in both time and space. The age of onset is between 20 to 40 years. Only 10% of cases presenting in the individuals older than 50 years. Female predominance of 2 to 1. MR is the most sensitive indicator in the detection of MS plaques, but imaging finding alone should never be considered diagnostic. MR typically demonstrates lesions in more than 90% of cases. This compares with far less than 50% for CT and 70 to 85% for laboratory tests. MS plaques are typically round or ovoid with periventricular or juxtacortical location. Lesions are bright on T2-weighted images, reflecting active inflammation or chronic scarring, and only a fraction of MS plaques will demonstrate contrast enhancement. T1, coronal contrast T1, shows contrast enhancement, and there is periventricular lesions in flared sagittal sections. Enhancing lesions are indicative of acute lesions with active demyelination and disruption of blood-brain barrier. In addition to the periventricular white matter, the cerebellar and cerebral peduncles are, as well as the corpus callosum, medulla, and spinal cord can be involved in MS. Ischemic changes are rare in these lesions. As a result, if periventricular lesions are accompanied by lesions in any of these areas, this dramatically increases the specificity for the diagnosis of MS. The pons is excluded from this list of posterior fossa structures due to its proclivity for small vessel ischemic injury. In contrast, because ischemic changes rarely involve the medulla and cerebral peduncles, the presence of lesion in this area is a useful differential diagnostic factor in suggesting MS. This is particularly important in patients older than 50 years because it is difficult to decide whether multifocal white matter lesions are the result of ischemia or a demyelinating process.
So you have more than 50 years old, there are multiple lesions. There are the lacunar parts are the MS lesions. You look for the lesions in the posterior fossa. Usually lacunars do not occur in the posterior fossa. When you see this is there or in the spinal cord, this is more in favor of MS.
Although the periependymal regions are posterior and posterior fossa location of white matter lesions certainly suggestive of MS, these findings are not diagnostic of MS as numerous other conditions such as lupus, antiphospholipid syndrome, and other angiopathic conditions may be the cause. In contrast to MS lesions, these hyperintense foci are typically located within the subcortical and deep white matter, often clustered in frontal lobe. MS lesions may also present as a large conglomerate deep white matter mass that can be mistaken for a neoplasm. These lesions are referred to as tumefactive MS or tumefactive demyelinating lesions. Conglomerate MS plaques often demonstrate a peripheral crescenting rim of contrast enhancement, which represent the advancing bleeding edge of the active demyelination. This point can be differentiated it from the neoplasm.
One unseen edge is more contrast enhancement, like symmetrical
Yes.
contrast enhancement. That's how you differentiate from neoplasm, for example. But it's not that easy, it's difficult.
Yes.
But in the advanced stage, not all over. Just in the advanced, one side yes and the others other. But it's not that easy. You usually mistake it for it. It's acceptable. And in this case, in this case, since it was mistaken for a tumor biopsy was done after the
Yes. Yes. The spinal cord might also be involved with MS, and whenever a focal abnormality of the spinal cord is detected, a demyelinating MS plaque must be in the differential diagnosis. Demyelinating plaques may have mild mass effect as well as contrast enhancements, thus mimicking a neoplasm. The majority of spinal cord MS lesions, about 70 to 80%, will have associated plaques in the brain. Ischemic demyelination, edge-related demyelination, the deep penetrating vessels supplying the white matter become narrowed by arteriosclerosis and leukohaline deposits. The result is the deposition of small ischemic lesions, primarily involving the deep cerebral and periventricular white matter, as well as the basal ganglia. Non-specific punctuate white matter lesions are more prominent in any patient with a vasculopathy, whether related to atherosclerosis, hypercoagulable conditions, vasculitis, or drug-related vasculopathy. The axial T1 image shows numerous dark signal periventricular lesions with associated deep white matter loss and ex vacuo ventriculomegaly. This chronic lupus cerebritis. Antiphospholipid antibody syndrome, T2-weighted images demonstrate scattered focal subcortical and deep white matter lesions. Moya disease, marked stenosis of the supraglenoid internal carotid vasculature with a dramatic proliferation of tiny collateral vessels presenting as a puff of smoke.
It's just like smoke.
Yes, it's Japanese.
More in the Japanese story.
Yes. Yes. Drug-induced vasculopathy, significant signal abnormalities are noted involving the cortex and the subcortical white matter of the high frontoparietal convexities. Ependymitis granularis is a normal anatomic finding that may mimic pathology. It consists of an area of high signal on T2 weighted along the tips of frontal horns and also occipital horns. This foci of signal range in width from several millimeters to a centimeter. And there is a magnet susceptibility artifact. Yes. 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 Prominent perivascular spaces can also mimic deep white matter or lacunar infarctions. As blood vessels penetrate into the brain parenchyma, they are enveloped by CSF and sheath of pia. These CSF-filled perivascular clefts are called Virchow-Robin spaces and present as a punctate foci of high signal on T2-weighted images. Multiple hypersignal intensities are seen in the centrum semiovale and in basal ganglia, but by proton density images, they are absent. This point can be differentiated between ischemic and CADASIL disease, it stands for cerebral autosomal dominant arteriopathy with subcortical infarctions and leukoencephalopathy. This condition presents with ischemic trends often in the middle age. The presence of subcortical anterior, temporal, medial frontal, and external capsule white matter are relatively specific for this condition. Yes. Infection-related demyelination. Herpes encephalitis is the most common fatal encephalitis. The form of herpes encephalitis, which occurs in children and adults, and is caused by herpes simplex virus type 1, oral herpes. This in contrast to neonatal herpes encephalitis, which is caused by herpes simplex virus 2, genital herpes. HSV type 1 has a particular predilection for the limbic system with the localization of the infection to temporal lobes, insular cortex, and subfrontal area and cingulate gyrus. This involving bilateral cingulate cortex. Acute disseminated encephalomyelitis, a post-infectious and post-vaccinal encephalomyelitis typically occurs after a viral illness or vaccination. MR image demonstrates multifocal or confluent white matter lesions similar to those of MS. A differential feature is that ADAM is monophasic illness, unlike MS, which has a remitting and relapsing course. Yes. This condition also involves gray matter, like in right vitamin and thalamus. Progressive multifocal leukoencephalopathy is seen in a wide range of immune-compromised individuals, ranging from those treated with immunosuppressants and cytotoxic agents to patients with AIDS. PML typically involve the deep cerebral white matter with subcortical U fiber involvement, but spares the cortex, and deep gray matter. Lesions are characterized by a lack of mass effect, contrast enhancement, and hemorrhage. Yes. Yes. Toxic and metabolic demyelination. Central pontine myelinolysis is a disorder that results in characteristic demyelination of the central pons. This is most commonly seen in patients with electrolyte abnormalities, particularly involving hyponatremia, that are rapidly corrected, giving rise to the term osmotic demyelination syndrome. MR characteristically demonstrates abnormal high signal on T2 weighted images corresponding to the region of central pontine demyelination. Posterior reversible encephalopathy syndrome is a condition characterized by signal changes within the brain parenchyma, primarily involving the posterior vascular distribution. It has also been referred to as reversible posterior leukoencephalopathy syndrome. MR revealing relatively symmetric areas of bilateral subcortical and cortical vasogenic edema within the parieto-occipital lobes. Radiation leukoencephalitis findings consist of areas of abnormal high signal on T2 images, typically involving confluent areas of white matter extending to involve the subcortical U fibers in the distribution of irradiated brain. Yes. Radiation necrosis and radiation arthritis. Radiation necrosis may occur several weeks to years after radiation, but it most commonly occurs between 6 and 24 months after radiation. Radiation necrosis typically presents as an enhancing lesion with mass effect and ring enhancement. And, and on follow-up MRI, the recurrent tumor will be larger. Yes. Dysmyelinating disease, metachromatic leukodystrophy. The head size is normal. Age of onset, infantile form is from 1 to 2 years. Juvenile form is from 5 to 7 years. White matter is diffusely affected. Gray matter is not involved. Adrenoleukodystrophy. The head size is normal. Age of onset is between 5 to 10 years. White matter involvement, symmetric occipital and splenium of the corpus callosum, while gray matter is not involved. Lake disease, normal, head size is normal, age of onset is younger than 5 years. White matter involvement, focal areas of cortical white matter, gray matter involvement, basal ganglia and periaqueductal gray matter. Alexander disease, the head size is normal to large, younger than 1 year. White matter involvement is frontal lobe. Gray matter is not involved. Canavan disease, the head size is normal to large, younger than 1 year. White matter is diffusely affected, while gray matter, vascularization of cortical gray matter. Metachromatic leukodystrophy is the most common of leukodystrophies, autosomal recessive pattern. The most common type is an infantile form that becomes apparent at approximately 2 years of age. MR demonstrates progressive symmetric areas of non-specific white matter involvement with sparing of the subcortical U fibers. Adrenal leukodystrophy is a sex-linked recessive condition occurring only in boys. Typical age of onset is between 5 and 10 years of age, presenting with symmetric involvement of the periarterial white matter with extension into the splenium of the corpus callosum. Leukoencephalopathy disease, also called subacute necrotizing encephalomyelopathy, is a mitochondrial enzyme defect that commonly manifests in infancy or childhood, usually younger than 5 years. Symmetric focal necrotic lesions are found in the basal ganglia and thalamus, as well as in the subcortical white matter. New subject, hydrocephalus, is caused by an obstruction of the CSF circulatory pathway and is classified into two principal types, non-communicating and communicating. Non-communicating hydrocephalus refers to an obstruction occurring within the ventricular system that prevents CSF from exiting the ventricles. Imaging reveals dilated ventricles with periventricular hyperintensity consistent with transepidermal flow of the CSF. And there's ventricular megaly. And on sagittal T2 weighted image shows thinning of the corpus callosum and upward convexity and ballooning of the third ventricle recesses, and the causative mass is large epidemoma in the fourth ventricle. In communicating hydrocephalus, the level of obstruction is beyond the ventricular system, located instead within the subarachnoid space. CSF is able to exit the ventricular system, but fails to undergo normal resorption by the arachnoid villi. In theory, with communicating hydrocephalus, most of the ventricular system is enlarged, whereas with non-communicating hydrocephalus, dilatation occurs up to the point of obstruction. The fourth ventricle often does not dilate because of the relatively confined nature of the posterior fossa and thus cannot be used as a reliable means by which to differentiate communicating from non-communicating hydrocephalus. Neurodegenerative disorders. Alzheimer's disease is the most common neurodegenerative disease and the most common cause of dementia. Neuroimaging studies of the patient with Alzheimer's disease demonstrate diffuse atrophy with a predilection for the hippocampal formation, temporal lobes, and parietotemporal cortices. As a result, enlargement of the temporal horn, supracellular cistern, and sylvian fissures may be useful in discriminating Alzheimer's disease from normal age-related atrophy. Parkinson's disease is the most common basal ganglia disorder and one of the leading causes of neurologic disability in individuals older than 60 years. MR images are relatively insensitive in detection of the disease. However, it may occasionally reveal thinning of pars compacta, which is sandwiched between pars reticularis anteriorly and red nuclei posteriorly. However, this finding is only occasionally noted in very severe forms of the disease. Huntington disease is a progressive hereditary disorder that appears in the fourth and fifth decades of life. The caudate nucleus and putamen are most severely affected. Atrophy of the caudate nucleus results in the characteristic enlargement of the frontal horns, which take on a heart-shaped configuration. Wilson disease, also known as hepatolenticular degeneration, is an inborn error of copper metabolism that's associated with hepatic cirrhosis and degenerative changes of the basal ganglia. MR findings include diffuse atrophy with signal abnormalities involving the deep gray matter nuclei and deep white matter. In addition to these neurodegenerative diseases, abnormalities of the basal ganglia can have a wide range of causes. Toxins such as carbon monoxide or methanol poisoning may result in signal abnormalities of the basal ganglia, characteristically the globus pallidus and putamen. Yes, methanol, putamen. Yes. I finished. Thank you.
Nice. Any questions, anyone?